Welcome back to the operatory. This is the live case demonstration for bonus number 1, relieving emergency endodontic pain on a time crunch. So like I mentioned in the didactic lesson, this is a demonstration showing you how I want you to utilize and perform an IRM pulpotomy when you're on a super time crunch and you have to relieve your patient's endodontic pain in a very short amount of time so it's not disruptive to your work schedule. All right, so this patient specifically had a composite restoration done just 1 week prior on tooth number 15. The patient's dentist warned them that it was pretty deep and there might be a problem, and like clockwork, it blew up on her and she had significant amounts of pain to cold as well as spontaneous pain and chewing pain. So when we did our clinical testing, we discovered that she had lingering cold pain, she had pain on percussion, palpation, and biting pain when she bit on the cotton roll. And radiographically, we can see that the composite restoration is quite deep on tooth number 15, coming very, very close to the pulp horn on tooth number 15. So that's the bite wing radiograph. When we look at our periapical radiograph, we can see that the restoration is still showing to be very deep. We have nice open canals, and we know that this is a nice case. So this is a younger patient. She was in her early 20s, and she was in a ton of pain. But I knew that even though I only had a few minutes to manage her, that I can get her to a state of being relatively pain-free up until I had enough time to perform complete endodontic treatment for her at a later date. So we decided to perform an IRM pulpotomy. Her diagnosis was found to be symptomatic irreversible pulpitis with symptomatic apical periodontitis. And this is the diagnosis that you're going to most frequently encounter when you decide to utilize this procedure. And again, this procedure is fantastic because it's so quick and easy to perform, and it performs such a valuable service for your patients because they're going to be out of pain almost immediately, and it only took you a few minutes of chair time. You'll see that this took about 6 minutes of clinical chair time, but remember, I'm messing around with the cameras, trying to get everything to look perfect for you, the viewer, and the student, but generally speaking, this should only take you, 3 to 5 minutes, let's say. We're going to start, obviously, with getting our patient fully anesthetized. So we've got that managed, and then we're going to go ahead and proceed with our rubber dam isolation. So we've got our bite block in, and we're going to place our number 12A clamp for tooth number 15. So once that's in place, we're going to go ahead and remove the rubber dam material over the wings and start our procedure. So you can see that the tooth is well isolated there, and as always, we're going to begin with the lowering of the occlusion, and in this case, I'm using the chamfer diamond to do that. So I'm just going to lower the cusps on the entire tooth, so we have a nice flat reference point, and so that we have a patient who doesn't have a whole lot of post-operative pain when she chews, since there won't be very much contact. And so we're proceeding now with our access preparation using our number 4 high-speed round burr. And remember, we're trying to get that nice, rounded, triangular form. You're going to see shortly that the patient actually just had a little bit of pain as we were getting very close to the pulp, so we're going to utilize an intrapulpal form of supplemental anesthesia. You'll see that shortly. We are going to begin by getting the majority of our access preparation prepared, eventually leading us into the pulp chamber of this tooth. So little by little, with our little brushing motions, getting closer and closer to that pulp tissue. The patient shortly will have a little bit of a jump, and I will be asking them, hey, it seems like you're feeling this. Are you still feeling any of this? And she goes ahead and confirms that, which is when I go ahead and perform our intrapulpal anesthesia. So So I'm getting down and boop, there we are, right into the pulp tissue. You want to make sure that you're actually in the pulp tissue and that you don't have any dentin covering the pulp before you give your intrapulpal. So if you have to do a little zip with your high speed, do that. If you want to give it a little poke with your Endo Explorer, that's fine too. In this case, I'm just going ahead and poking so that I have clean access directly to that pulp tissue. And now I'm using that bent short needle and administering the intrapulpal anesthetic with this Visceptacane. And the patient is now 100% anesthetized, so that's good. So now we're going to go ahead and proceed with our access preparation using our number 4 surgical length high-speed round burr. And we've already gained access into a portion of the pulp chamber, and now we're just unroofing the remainder of that pulp chamber. This is going to be what takes the majority of the time. And so the whole goal, while I'm modifying the access preparation, the whole goal of this pulpotomy is to have a completed access preparation, a completed canal identification, and removing the pulp tissue in just the pulp chamber. If you start poking into the canal orifice and using your orifice opener and poke into the canal orifice, the patient's actually going to have more pain potentially than what they started with. So the goal here is to not get into the roots, but only to get into the pulp chamber. And there's a spectrum as to how much bleeding is going to occur relative to oftentimes how much inflammation is present, at least on a pathologic or a microscopic level. And so if you're finding that there's a ton of bleeding and that's preventing you from being able to see what you're doing, then I want you to use a cotton pellet soaked in sodium hypochlorite and just press it into the pulp chamber. What that's going to do is it's going to control the bleeding and thus enable you to be able to see what you're doing. But in this case, we were able to manage the bleeding without using sodium hypochlorite. So you can see the pulp tissue is there. And so, like I mentioned, in terms of our canal identification, you don't want to use an orifice opener and start poking into the canals. So I'm using a spoon excavator here and just removing all that pulp tissue in the pulp chamber. That way I can visualize the canal orifice, and I'll be setting the stage for her next appointment where we will be performing the complete endodontic treatment. So now the bulk of the pulp tissue is removed inside the pulp chamber, and I'm going to use a pellet here and just press it in the chamber just to control that bleeding and to make sure that I can see all the canal orifice. This is a dry pellet, but again, if you're feeling like there's so much bleeding that's occurring, then soak your pellet in sodium hypochlorite and use that, and that's going to help with that hemostasis. And so we can see actually that we have 4 canals in this case. You'll actually notice that I have an MB1 and then an MB2 just below it, and then a DB in the palatal. And now that the access preparation is complete, we're going to place our IRM. So I've already told the dental assistant to start mixing the IRM as I'm working. And now that that access is done, I'm just going to deliver it with the Glick instrument or the paddle or the composite instrument, whatever you want, and deliver it to that area. And you want to overfill it just like you would with an amalgam restoration, so that when you burnish it down, you have a nice, well-fitting and well-sealed sedative filling. And now I'm using a moist cotton pellet just to burnish that and make sure that there's not too much excess present. And you can see that was such a quick procedure, and this patient is going to be pain-free most likely by the time they wake up tomorrow. You are going to recommend some medications for this patient, like I mentioned in the didactic lesson, but that's all it takes to get this patient to a state of where they have a form of pain that they can manage with Advil and Tylenol. It oftentimes is going to get them down to a point that it's imperceivable. So I would highly recommend that you utilize this procedure for your patients who have symptomatic irreversible pulpitis, regardless of the periapical status, because it's a great way to get them out of pain in a very short amount of time, so it's not disruptive to your day, so it's not a burden on your staff, and you don't throw your hands up and refer this patient out simply because you didn't want to spend the 5 minutes, or you didn't know that you could only manage the patient in 5 minutes and then get them to their scheduled endo appointment. All right, I hope you appreciated this bonus lesson. We're gonna work into more and more super relevant material in the remainder of the bonus sections, and I will see you in the next bonus lesson.